I mean, that's the mission of our organization is to advocate for quality, affordable, accessible healthcare. And for rural areas, accessible kind of is that key part that's missing a lot of times. There's not as many doctors. Our rural areas are under major healthcare workforce professional shortages. And there just won't always be because of, population. So how do you provide access to care is our number one issue that we work on. We've passed a lot of legislation in the state to make telemedicine easier for hospitals and providers to implement and to get paid for. So we're one of the few states where both private and public dollars will pay for telemedicine, access to specialty care via telemedicine. There's also, we've done policy work to make it easier for hospitals to credential and credential the providers that provide telemedicine. So you can imagine if you're a physician from outside the areas providing care to a patient in a rural area, that hospital needs to go through a credentialing process, and we've made inroads in making that process easier. We have a robust loan assistance repayment program in Maryland, so incentivizing physicians to go practice in rural areas by forgiving their medical loans. We have both state and federal funds that go towards those programs in the state. And one of our biggest partners is, and really what the best way to kind of provide access to care and to eliminate workforce shortages is to have a robust workforce healthcare pipeline so that you have kids early on interested in being physicians, have the right education to be physicians, go off to college and study the right pre-majors, go to medical school, and then be able to come back to their rural areas and practice. And we work in partnership with our area health education centers that on the shore, the Eastern Shore Area Health Education Center works on that mission. Yeah. The transportation issue, for sure. I mean, that is across the state in rural areas is a big issue. And how you get patients to where there is care is something we've worked on and will continue to work on. One model that's trying to deal with the transportation issue in rural Maryland is we have what's called health enterprise zones. We have one in Caroline and Dorchester. We have one in St. Mary's that are funded to bring healthcare stakeholders together and work on improving the health of a small group of population. In St. Mary's, transportation is one thing they are looking at. They are funding with their health enterprise zone dollars a bus that helps deliver patients to care. A health enterprise zone, it was a competitive process a few years back. We had 19 applications across the state, 10 came from rural areas. So, and that the thought to that innovative program is to improve the health of a population that has disparities, and we have true health disparities in rural Maryland. Yeah. And so that was a success in that program wasn't going to actually be targeted towards rural areas. We advocated that it should be, and as a result, 2 of the 5 zones are in rural areas. One of the great things they're doing with those dollars is funding community health workers, which is huge, a huge new model that really works in rural areas. So you train people that aren't traditionally part of the healthcare system to help someone navigate the healthcare system, if that makes sense. So so a community health worker gets some basic training in health terminology and health language, and then they're able to, hold the hand almost of a patient through, difficult situation and health system. So in Caroline Dorchester, they're doing a lot of community health worker training. And that's a model that's most likely going to expand across the state. And the state's looking at how we pay for those workers and investing dollars in community health workers. But Maryland's very unique. Since the 70s, we've been working under a waiver from the Center of Medicare and Medicaid. So our hospitals get paid in a very unique way. It's an all-payer system. So we have a waiver from Medicare to set rates for our hospital rates internally to the state. So we have the HSCRC, which is the Health Services Review Costs Commission. I may have not gotten that all right. and they are like a statewide commission that's appointed, and they set, they look at the huge economic perspective from Maryland, and they set the rates that hospitals are set, and have been doing that from the 70s. Because to contain costs, you have to collaborate. You have to be talking, the hospital has to be talking to the skilled nursing facility. They have to be talking to the health department. And a lot of communities, in rural communities, they do that under the umbrella of local health improvement coalitions, which we have across the state, that bring those partners together to talk about, you know, how do we collaborate, how do we coordinate care for our most vulnerable patients.
And have you seen some success stories with that?
Oh yeah, for sure. Yeah, I mean, the HES that I talked about in St. Mary's County came from, you know, local health improvement coalition, where the, you know, health department and hospital and community partners all work together to say, this is what, you know, we need to better coordinate care for our region. You know, our shortages are not going away. I mean, if there's one thing, and right now when we talk about coordinating care, the person that needs to do that most is that primary care provider. I mean, what's on the back of primary care providers right now is tough. It's really tough. And for rural areas, when you're lacking, you know, physicians just normally to do that, and now you're under this new health system transformation where care needs to get even more coordinated. So important to have primary care providers. So I would say that that is a huge area of need for the Eastern Shore and all of rural Maryland. And it's not just physicians. One where we're making strides is nurse practitioners are primary care providers. We are in the state of Maryland, nurse practitioners can be primary care providers and practice to their fullest scope of their ability, what they're trained to do. In other states, they can't. So that's a real positive for rural areas. I mean, I will say in my work, I've been working with Maryland rural communities for, you know, about 10 years now, and they do it so well. I mean, rural healthcare providers, they have to wear so many hats that they know. I mean, because of that, I feel like they're the best providers out there, because they've just had to manage, you know, had to take care of patients under less access to care. Yeah. And in other states, there's a type of provider that's drawn to that, you know, and is a really good provider, and we have to kind of cultivate that a little bit more. We're under a new model as of 2014, so we're only very in its infancy, but costs are lower, people are coordinating care better. So, you know, it's working. There's still a lot of work to be done. How does it translate down to the consumer level? You know, I'm part of a statewide group that's trying to digest that. You know, how do you engage patients in this dialogue? Do patients even need to know that we're under this new AllPayer model? What does that mean? And there's a lot of good people working on how do you communicate that, and so that an individual patient understands it and is able to understand how it might be affecting their care.
Tell me how.